Good afternoon, everyone, and welcome to our 2024 series of virtual Grand Rounds, Emerging Public Health Issues. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's session on the CARE Act, Understanding a New Model for Mental Health Treatment in California. We've all read and heard, and perhaps personally experienced, the challenges of caring for individuals who have severe mental illness and who are at high risk for homelessness, incarceration, and death, as well as significant physical health and safety needs. The CARE Act aims to help the care system serve the needs of those who have fallen through the cracks by providing robust and comprehensive services, including behavioral health services, stabilization meds, and housing. While court-ordered care, quote unquote, often has a negative connotation, Dr. Catherine Warburton is here today to help us understand how this new model is different from other civil outpatient models in the US and how it supports the needs of the most vulnerable, and how we as clinicians can participate on behalf of our patients and petition the court. We'll also hear from our usual speaker, Dr. Erica Pan, who will review the current status of COVID-19, influenza, and other respiratory winter viruses. Before we start, I just want to acknowledge CDPH as our incredible partner in providing relevant public health education for physicians in California. Here are our speakers' disclosures. Next, please. This is our that was our agenda for today, and here, just as a reminder, is that our series is accredited for CME credit, and you'll be sent a survey after the completion of the webinar. You have to attest to your attendance, and once you do that, we'll send you out your certificates. So let's just go ahead and get started with Dr. Pan today, and we are very grateful to have her as always.
Great, thank you so much, Kim, and Happy New Year, everybody. I'm looking forward to 2024 and a new year. And as Kim mentioned, I'll just kind of jump right into what's going on with respiratory viruses, because we are certainly in the season. Next slide, please. So I thought today I would do sort of my usual kind of overview of where we are as a state as far as a lot of the significant respiratory viruses, and then a focus on our highest risk populations as certainly a theme of the day in general, but just really want to highlight some concerns and challenges we have related to our most vulnerable populations and getting prevention and treatment to the right people. And then a little bit of, on that note around treatment, some new studies that just came out about rebound and long COVID with oral antivirals, and just a segue then to our main speaker. Next slide. So you will see this on our dashboard. We are now doing this every Friday with some data that we still continue to track on COVID and flu, actually, which you'll see in a moment, but for new hospital admissions, deaths, and tests. And you can see the trends, and certainly as we typically see at the end of the year and in the winter, we've seen some increases in hospital admissions. You have a little bit of a fall off there as far as lags in reporting as far as deaths, but very sort of stable or similar to recent patterns with our last big surge in the late summer, early fall. And then test positivity is certainly going up again, which we continue to monitor and is a helpful trend in looking at PCR test positivity. Next slide. How does this compare to prior years is, of course, what I think many of us are all continuing to look at and wonder, especially as we consider how to continue to incorporate this previously pandemic virus that really is now endemic and part of our winter respiratory virus season. So you can see the darkest dark line here is the 23-24 season. You can see that as far as new hospital admissions, similar trend compared to last year as far as when we started seeing increases, but lower than previous years for sure. So thankfully, again, lower impact, still causing some serious hospitalizations. And then on the right here, you see deaths, but again, lower than all of our prior seasons and certainly during the pandemic. Next slide. And then flu, we've also updated our kind of general dashboard to have similar data for flu. So again, that's where we're actually seeing the most increases recently in the last couple of weeks is in flu hospital admissions, and what's really driving increases in hospital kind of censuses right now as far as respiratory. And then reported deaths have also increased. These are at lower numbers than COVID as far as comparing them, but again, a milder season than before, which actually I'll show you in the next slide. Next slide, please. So you can see this arrow here to our current season. So it's the black line, and you can see one of our worst flu seasons in the last several years was 2018-19. That's where the really big orange spike is. That had peaked much later that season and much higher as far as hospital admits. And then last year is the one that's sort of a dark green that you'll see. We had a very early season last year along with RSV. And this year we're having a little bit more typical to a lot of prior seasons here in California, where we're seeing the increases now. We may be seeing that we've peaked. That may or may not be a lag in artificial because of hospital holiday reporting or not. So I think next week will be really telling to see if that trend continues to go down or if there's another secondary bump. Next slide. And then this is just to kind of demonstrate again too that there are of course many other respiratory viruses circulating as well. So this is from some of our Sentinel clinical labs, and you can see again there's some increases in COVID. RSV is actually plateauing and decreasing now, thankfully. So we're not having peaks at the same time, which was a big concern and what we had seen very early last winter season. And then flu, this is again percent of outpatient visits for ILI. Flu is increasing and increasing the most on this graph. And then you can see other viruses are continuing to circulate as well. Next slide. And then another way we look at this is ED visits. This is from the National Syndromic Surveillance Platform. And here also you can see that overall flu is the blue line, and the one that had been increasing the most in the last few weeks may be plateauing again. And then COVID is increasing but slowly and less than flu. And then RSV, as mentioned, and as you've noted, so that other data seems to be plateauing, which is reassuring that hopefully we may be over the worst as far as the RSV. Next slide. And then the other thing, the tool we have now that actually we can follow not only COVID-19, but also flu A and B and RSV across the state are wastewater. They are certainly high levels across the state right now, increasing in some regions, maybe plateauing in others. I think the other thing, there's been some national coverage of this as well, that we are seeing very high wastewater levels compared to previous peaks in COVID. I think what's interesting about that is, and some of the hypotheses are, well, is this actually that we're seeing more mild infections in people that are not getting tested or reporting tests or seeking healthcare, or are there other reasons? Is there more shedding of the most current circulating variants, et cetera? But the really important data is to be able to look at this, but also see, as I was showing you, what is the impact on hospitalizations and deaths. Next slide. So again, bottom line, we are seeing some increases in COVID-19 activity, especially often after the travel and gatherings of the holiday season. It's very typical in our winter respiratory virus season to see some high levels around December, January. We're continuing to monitor this. We may or may not be kind of plateauing or peaking, so time will tell. Similar with flu, which is really the one that's increased the most recently. And has the highest healthcare impacts, and we do think maybe that the peak has already happened for RSV activity. And with that, but what we did want to note on the next slide is that the use of nirsevimab updates have been issued soon. And so I want to focus on the extremes of age, which are the groups that really have the most morbidity and mortality from these respiratory viruses. So infants and elderly are really the ones we see hospitalizations and deaths with RSV, flu, and COVID-19. Next slide. So for nirsevimab, you may recall that on one hand, we're really excited this year to have a new way to protect a broader spectrum of infants and not have to do a monthly dose of an antibody. And then there was not enough. But just on the January 5th, the manufacturers and CDC have said there's another bolus of doses coming out. So healthcare providers really should return to the original recommendations about providing nirsevimab for young infants, not trying to reserve it at this point in the season. It's definitely, on one hand, not too late, and actually you don't want to reserve it later because right now we're still seeing high levels of activity, and this is a passive immunization with an antibody that can provide almost immediate protection. So really don't be reserving your nirsevimab anymore, and there's more coming, so please go ahead and start giving that to infants that are eligible. Next slide. So I also just want to highlight, on the other end of the spectrum, the elderly and where we are on vaccine coverage in California. So of course, again, the highest risk for hospitalizations or deaths with COVID-19 is age, and our over 65 population, only about 30% have gotten the most recent booster for COVID-19, and you'll see only about 12% of our population has been vaccinated at all this fall. So really, really low rates for vaccination, including in our highest risk population. Next slide. And then shifting to, and actually my other kind of comment before I shift to nursing homes is that overall for flu, unfortunately every season it's pretty consistent, about half of the population gets vaccinated, but we're even less than flu this year. Maybe because it's newer, and I just really want you all to continue to promote not only flu vaccine, but also COVID-19, and then we'll talk a little bit about the RSV vaccine as well, and the data we're seeing for vaccine coverage there. But as of the end of the year, only about a third of residents in nursing homes and only about 10% of staff in nursing homes have received the most updated COVID-19 vaccine. And again, as we know, this is where we see outbreaks, this is where we have the most deaths, and certainly the most hospitalizations in this high-risk setting. So we really want to work with your patients who are in nursing homes and with the nursing homes themselves and medical directors to really improve that vaccination rate. Next slide. And this is kind of a snapshot by state of how we are doing compared to other states for not only COVID-19 vaccine, but flu and RSV. So again, California is not actually doing as well for RSV. You can see actually in the Midwest, there's a lot of higher coverage in nursing homes for many of these viruses, but really just not seeing the levels we would like to see of coverage and vaccination amongst our most fragile residents. Next slide. And so also shifting to the other tools we have, right? We have all kinds of prevention that we can do, and vaccines are one of the most important of those. And then for those that do become infected, early treatment is incredibly helpful to keep people out of the hospital and mitigate the severity of disease. So just a reminder, I think I've had this on almost every time I've been on, but we have a best practices toolkit around treatment. We have a whole campaign right now for Test It and Treat It, and some of the supplementary slides will cover other resources and links for toolkits and other things that you can help promote. And some recent data, again, that people are just not utilizing it. I think it's about 40% of eligible adults who are eligible for Paxlovid are not actually taking it or getting prescribed. Next slide. So one of the common sort of concerns that people have is, oh, if I take or prescribe Paxlovid, is there increased risk of rebound? There will continue to be data evolving on this, but the CDC did just post an MMWR recently on this and looked at several rebound studies among patients who did and didn't receive antiviral treatment, and there was not a consistent association between treatment and rebound. And really importantly too, the rebound symptoms were mild. None of the hospitalizations or deaths occurred from viral rebound. So really just want to emphasize again that that is not a reason not to prescribe antivirals to someone who is eligible and who could benefit from the decreased severity of disease. Next slide. And then there is another study. I think we were hoping and seeing some early data prior to this one suggesting that because Paxlovid and antivirals do decrease your viral load and how long you're shedding, that perhaps that could decrease the risk of long COVID. It also results in faster viral clearance overall. There was a recently published study around this during March to August of last year that said there is no association with a lower prevalence of longer term symptoms after 90 days after infection. So unfortunately, this recent study did not show an association with decreased long COVID symptoms. But again, so recent data, but the benefits of preventing hospitalizations and deaths are really important for our vulnerable populations. Next slide. And again, just kind of reiterating, in our nursing homes and skilled nursing facilities, only 1 in 4 residents had been treated by the end of 2022. That was last year when COVID was even more on people's minds and we had more available treatments that were free. There has now been a shift to commercialization, but health insurance plans, and we have a chart at the end of the supplemental slides as well to show you the latest on what should be covered in California or not. But 40% of nursing homes reported that they had never administered a treatment for COVID-19 in the 19-month study window. So really, really concerning again that we have this tool now. It's easily available, oral antivirals. And there's a lot of great tools out there too, and there's concerns about drug interactions, and many drugs can be held for the 5 days of treatment without a lot of long-term consequences. So it's really, really, I think, a tool that we want to see used more. There were some outbreaks in the last sort of end of summer, early fall in nursing homes where there were deaths of skilled nursing facility residents who had not received vaccination or treatment. And again, we have these tools that can help prevent this morbidity and mortality. So please help us promote this in these populations. Next slide. And then another tool, I just wanted to make sure those of you who do care for patients in skilled nursing facilities, our Healthcare Associated Infections Program has posted some recommendations for COVID, flu, and switch-viral viral infections for this season. Has some just key messages and tools about making sure people, residents and staff are up to date on their vaccines, some policies around source control masking during the height of the season, such as right now, and just other, again, key prevention messages around keeping and monitoring, what's happening in your local community, indoor air quality and ventilation, and all of the other kind of key infection control and prevention practices that are best practices, and how to deal with outbreaks as well in these settings. Next slide. And then as a segue to the really, really important topic for our next speaker, I won't read all of this to you, but wanted to highlight again that this pandemic really caused so much distress and mental health kind of challenges, I think, for everybody, and especially amongst not only just our entire population and adults. We're certainly seeing this in our young children and our teens. The chronic stress of having such a prolonged pandemic and the isolation that we saw have really caused incredible stress and mental health challenges. And certainly amongst public health and healthcare workers in the US as well, we're just seeing a lot of burnout. And this is data kind of really talking about more resourced individuals. And I know a really important topic, that we're about to dive into is thinking about our most vulnerable. But if we're seeing this much, this high of a prevalence of mental health challenges, and I'd say also, it didn't pull the data for today, but a lot of our leading causes of death, especially in younger individuals in California and beyond, are all related to mental health challenges. Next slide. So with that, we are certainly in sort of, some high levels of virus transmission. Flu is one of the biggest drivers of that right now. We're hoping that we may see that level off in the near future, but it's not too late to get vaccinated and promote vaccination, especially amongst your highest risk patients, and also just really continue to help us promote treatment utilization. And we've really, again, magnified the mental health, behavioral health challenges. We really all want to prioritize our most vulnerable. And another just recent kind of link to let you all know about is our opioids crisis website that the Department of Public Health just updated recently with a lot of tools and resources there. Next slide. So with that, I just wanted to, remind you about all the great tools we have. If you layer them all together, they can help prevent all of these respiratory viruses. And I will turn it over to our next speaker. Thank you all, and Happy New Year.
Thanks so much, Erica, as always. Love that Swiss cheese image. Now I'm really thrilled to introduce Dr. Catherine Warburton, who is a board-certified forensic psychiatrist. She's the medical director and deputy director of clinical operations for the California Department of State Hospitals, a position which she's held for 13 years. She also serves as a volunteer clinical faculty with the UC Davis Division of Psychiatry and Law. Dr. Warburton's areas of interest include public policy, public forensic mental health care delivery systems, and inpatient aggression. She's presented both locally and nationally on several forensic topics, and recently co-edited textbooks on decriminalizing mental illness and on violence in psychiatry. So we're grateful to have her here today. Take it away, Dr. Warburton.
Thank you. Can you hear me?
Yes.
Great. Okay, so my experience over the last decade as the medical director for our state hospital system has provided me with a lot of context around care, and I'm going to spend the first portion of this discussion sharing that context with you so that you can understand why care is so critically important for this extremely vulnerable population. And I'll spend the second portion of this talk really diving into the CARE Act in general and your role specifically as physicians. Next slide, please. I appreciate that I am talking with physicians, so I won't belabor this, but for those of you who did your psychiatry rotations many years ago, I'm just going to talk a little bit about what schizophrenia spectrum disorders are. If you can just put up all my bullets, then I'll just run through. So schizophrenia spectrum disorders are usually diagnosed in late teens or early adulthood. They often have a prodrome where a otherwise normal, well-adjusted teenager starts to exhibit symptoms of functional deterioration that precede the obvious psychotic symptoms. The prevalence of schizophrenia spectrum disorders is around 1%. People with schizophrenia die 20 years earlier than the rest of us, and this disease is one of the top 15 leading causes of disability worldwide. And I'm going to focus today on diagnoses of schizophrenia and schizoaffective disorder. There are other disorders on the spectrum, but those disorders probably won't be seen in care as often. Next slide, please. So the symptoms of schizophrenia, I'm going to focus primarily on the first two. Hallucinations, as you might recall, are when an individual perceives things that are not there. And in this population, the individuals usually are perceiving voices or auditory hallucinations. And oftentimes in this particular population, those voices are telling or commanding the patient to do something, oftentimes with dire results if they do not comply with those commands. The second symptom that I really want to focus on are delusions, where an individual misperceives reality through false beliefs. And in the population I'm discussing, it's often paranoid or persecutory delusions that drive a lot of the behaviors that cause the outcomes that I'll describe in a moment. So those are positive symptoms, hallucinations and delusions. And the good news is that our antipsychotic medications are most effective with those positive symptoms, which are the symptoms that tend to result in criminal justice involvement. Individuals with these disorders also show disorganization in speech and behavior and what we call negative symptoms, which are most often diminished emotional expression and avolition. The difference between schizophrenia and schizoaffective disorder is schizoaffective disorder includes a mood component. And notably, the majority of patients who have schizophrenia spectrum disorders are not aware that they're ill. Next slide, please. This slide is just to put some science behind what I've just said, that what we call a nosognosia, or a lack of awareness of having an illness, is very common in schizophrenia. Some studies peg it at around 60%, or the majority. And this anosognosia has a major impact on the course of illness and causes treatment non-adherence, and is sort of part of the foundation of why we need care for it. Next slide, please. So I'm just going to ground us in an actual case vignette. This is an actual de-identified patient who is sent to us as incompetent to stand trial, and is a very common scenario that we see. So this individual was a 37-year-old homeless male. He was at a Jack in the Box restaurant. He refused to leave, so people called the police. When the police came, he stepped outside without incident. The police began to search him and tell him he was not welcome at the Jack in the Box. When the police officers put their hands on him, he became extremely upset and tried to get out of the grasp of the officers. It then became clear that he was experiencing delusions because he tried to call the police on an imaginary phone. He actually believed that the police officers were the devil. He was missing his left eye, and he told the police that he took out his eye because the devil told him to. So here we have a persecutory delusion about the devil and auditory command hallucinations, causing the patient to do extreme behaviors. Because he believed the police were the devil, he fought for his life. He was fighting for his life, and he fought the police officers. And he was obviously very, very upset because he did not respond to the initial tasers. And in this case, he was charged with felony battery with injury on a police officer and resisting an executive officer. So this is a very common scenario where positive symptoms of schizophrenia are mislabeled as criminal behavior, and these individuals are winding up in the criminal justice system. And my system, the state hospital system, which is a 6,500-bed forensic hospital system in California, we're sort of the on-ramp to criminalization, if you will. Next slide, please. Just some other outcomes. While people with schizophrenia make up only 1% of the overall population, they make up 20 to 30% of the homeless population. I just saw some HUD data today indicating that might be increasing. Individuals with schizophrenia make up 15% of state prison populations and 24% of jail populations. So terrible, terrible outcomes with this disease. Next slide, please. This is a complicated slide, and I won't belabor this, but what I want to try to demonstrate with this slide is that the poor outcomes with individuals who have schizophrenia have been cyclical historically, and I want to convince you that we're on a new cycle now with the so-called IST commitment to have a massive problem with reinstitutionalization of people with serious mental illnesses. So in the green bars, we're just talking about the history of state hospitals, or I'm sorry, the orange bars. And prior to the mid-1800s, essentially people who had psychotic disorders were locked in cages, jailed, or chained to walls, just horrifying conditions. And so in the middle of the 1800s, society in America and around the world decided to do something about it, and they built these beautiful asylums as a respite to deliver moral treatment to individuals who had psychotic disorders. But as you can see by the green in the orange bar, by the middle of the 1900s, those same patients were again experiencing extremes of neglect and poor conditions as these state hospitals became grossly overcrowded with 500,000 individuals in those hospitals. And the papers ensuing thereafter, starting in 1972, a few years after deinstitutionalization, these are just papers indicating that there's a trend of reinstitutionalization of individuals utilizing this incompetent to stand trial commitment. And essentially what an incompetent to stand trial commitment is when an individual is so psychotic that they don't understand the charges against them and they can't cooperate with their attorney. So in many ways, an IST commitment can be considered a proxy for an individual with a psychotic disorder being arrested. Next slide, please. Penrose effect, or Penrose's law, is named after a paper in 1939 where a British psychiatrist described an inverse relationship between the number of patients in mental hospitals and the number of sentenced adult prisoners. And this is a talk unto itself. Penrose's law has been demonstrated internationally in many, many studies. Next slide, please. But this here is a study from the United States. I'm sorry, my citation looks like it's cut off. And you can see in the dashed line individuals in mental hospitals going down around the time of deinstitutionalization, prison rates going up in terms of US rates of hospitalization. So our own United States data demonstrating the Penrose effect. Next slide, please. And here's just another study looking at the percentage of jail and prison inmates with serious mental illness going up quite a bit post deinstitutionalization. Next slide, please. So deinstitutionalization really started here in California, as many things do, with the Lanterman-Petra Short Act. And if you recall the slide that showed by the middle of the 1900s, we had 500,000 individuals living in state hospitals. It became a crisis. It was a crisis in California and nationally. And so one of the drivers behind deinstitutionalization was that these institutions were expensive, they were inhumane, and individuals were indiscriminately locked into these institutions. So a whole host of humanitarian reasons driving deinstitutionalization, as well as cost. But there's good news too, and that was around that time, our first antipsychotic medication, Thorazine, had been discovered, and there was great hopes that this could stabilize folks with schizophrenia spectrum disorders and help them reintegrate into their community. Next slide, please. This is another sort of look at the inverse relationship between carceral populations and hospital populations. This study is a little bit different in that this is looking at local psychiatric bed capacity. So not state hospital beds, but your community psychiatric beds. And when there was a reduction to local psychiatric bed capacity, it was significantly correlated with an average increase of jail inmates. And I'm sorry, I don't know why my citations aren't on here, but I'll make sure a deck gets circulated that has those. Next slide, please. So one thing that I want to make very, very clear is that the Penrose effect does not represent a dichotomous choice for societies. We don't have to choose between locking people up in mental health institutions and locking people up in prisons. That's reductive and erroneous. In fact, the Penrose effect is mediated by the symptoms of untreated mental illness being relabeled as criminal behavior and driving people who are not receiving mental health treatment into carceral settings. And this is the population that CareCourt is designed to intervene upon. This is the population that we see washing into our state hospitals at ever increasing rates as incompetent to stand trial. Again, this is the crux of the matter. We don't have to make a choice. If we treat individuals humanely and comprehensively in the community, we don't have to have individuals locked up in either type of institution. Next slide, please. This is just a study going back for a moment to the incompetent to stand trial crisis, showing major increases in IST patients in state hospitals from 1999 to 2014. And this is actually a flat part of the curve. Our true crisis in California started in 2014, and we're seeing increases of 10 to 20% in people being referred to us as incompetent to stand trial every year. Next slide, please. We've done a tremendous amount of research with our partners at UC Davis on this population. We have a sample size in the thousands. And what we can tell you about these individuals is they are individuals who have a schizophrenia spectrum disorder. 2/3 of them are experiencing homelessness at the time that they are arrested on the charge for which they're found incompetent to stand trial. Almost half of them have not received any Medicaid reimbursable mental health services in the 6 months prior to their arrest. And those that do are largely seen in emergency rooms. And if we have any emergency department physicians on this call, I'm sure that's no surprise to you. One of the problems with the IST commitment is that people are sent to us because they're incompetent to stand trial. And constitutionally, they have a right to a fair trial. So this is a constitutional issue. They come into us. We stabilize them. Oftentimes we stabilize them fairly quickly, and what that really means is providing them with antipsychotic medication to diminish those delusions and hallucinations of their mental illness, and we restore 90% of people to a place where they're competent to stand trial. Unfortunately, at that point, our role stops, and they are sent back out to the community. The majority, 75% of these people either get time served or have their charges dropped. They're sent back out to conditions of homelessness and lack of treatment. And so 70% of these individuals are rearrested within 3 years of us discharging them. So this IST commitment is not doing anything to interrupt the trajectory, the downward trajectory of these individuals' lives. and it's not doing anything to ensure public safety. And as I mentioned, referrals to our state hospital system as well as state hospital systems all over the country are skyrocketing. So this cycle of criminalization contributes to long-standing inequities where those with severe behavioral health conditions experience greater rates of chronic homelessness and incarceration. And this is why we need Care Court. Next slide, please. We did a national survey in 2017. We sent it to 51 jurisdictions, so all 50 states and the District of Columbia, and we asked mental health leadership in each state what they thought was driving the IST crisis in their state. So this was an opinion survey. This is answered by individuals like mental health commissioners, state forensic directors, state hospital directors. And these were the top 4 reasons provided from a national perspective about why more and more people with schizophrenia are being arrested. And those answers are inadequate general mental health services in the community, inadequate crisis services in the community, inadequate numbers of inpatient psychiatric beds in the community, not state hospital beds, and inadequate assertive community treatment services in the community. Next slide, please. And you can kind of see that's that Penrose effect, that study I showed you, where the factor driving people back into the carceral system are the untreated symptoms of mental illness. Digging into one of those answers around community hospital beds, this is a study of police discretion where they looked at what influences the decision-making of a police officer when they're deciding between arresting someone and booking them into jail or bringing that person to an emergency room. And in this study, the most important factor was whether the officer thought that person would be admitted to a hospital bed. Next slide, please. Factors positively associated with high-frequency incarceration. This is a study showing that the 2 most common factors are schizophrenia spectrum disorders and homelessness. So again, right on the same parameters of the population we're discussing. Next slide, please. So I just want to use another case just to remind us who we're talking about here. You'll start to see a theme with these individuals. This is another de-identified case that was admitted to us as incompetent to stand trial. This was a 45-year-old transient male who went into a sandwich shop and believed he owned it. As such, he locked the back door and put crates in front of it because he said the door was busted. He then went into the bathroom, he cleaned it, and expressed concern that someone might slip on the water on the floor and asked the clerk to make sure that didn't happen. He then asked the clerk for some money, saying, "Don't worry, I'm the owner." He was denied without incident. He then asked for a sandwich. The clerk became frightened. She ran out of the store and called the police. When the police got there, he was overtly delusional, talking about owning stores and talking about Tony the Tiger. So again, here we are, an individual with delusions being relabeled as criminal behavior, and he was charged with felony false imprisonment and attempted robbery. Next slide, please. So this is our hypothesis about what's driving this crisis in individuals being arrested who have serious mental illness, which is that individuals who have schizophrenia spectrum disorders are drifting into an untreated, unsheltered condition. These conditions are leading to increased contact with the police and criminal charges. This is leading to a surge in IST referrals to state hospitals. And what we found, for those of you old enough to remember the movie Field of Dreams, is that anytime we build more hospital beds, the referrals increase. So if you build them, they will come. And we really need to find something prior to that felony arrest to prevent that felony arrest, to prevent the criminalization and institutionalization of individuals with schizophrenia spectrum disorders. So what can we do? Next slide, please. Again, this is just a graphic representation of individuals who have serious mental illnesses, who are in the community, untreated, unsheltered, being arrested, spending long wait times in jails to come into us. They stay with us only long enough to get stabilized on medication so that they can stand trial. Fully 75% are returned to the community, where they are again untreated and unsheltered, and 70% recidivate, and the cycle continues. Next slide, please. So Care Court is designed to break that cycle. So there's your context. This is what we're trying to do with Care Court. As a civil court process, CARE is an upstream diversion designed to break the cycle of homelessness, criminalization, and institutionalization. The success of CARE will be based on whether this process can connect the respondents to the right services and supports, including what we are calling the three-legged stool: stabilization medication, wraparound behavioral health services, and housing. Next slide, please. Just to put CARE into context, this is something that's very familiar to forensic professionals. This is called the sequential intercept model. And what this does is it maps any place where an individual who has a serious mental illness could come into contact with the criminal justice system. And it's generally accepted that the further upstream, the earlier intercepts are a much more effective and humane way to divert and decriminalize individuals with serious mental illness. And so that we have our own diversion programs in state hospitals, but Care Court is an attempt to do the right thing, which is to move that diversion of individuals with serious mental illness away from the criminal justice system earlier. Next slide, please. So here it is listed out the CARE eligibility criteria. I won't go into too much detail. We do have a fact sheet attached to this, this talk, but if you read through it, you'll find that it's the target population is really the target population that I have been describing today. So we're trying to catch people before they get that felony arrest, but after they have demonstrated a profound need to prevent things like involuntary hospitalization, incarceration, institutionalization, or homelessness or death. Next slide, please. Here is the statutory language describing what a care plan means. And as you can see, it's that three-legged stool of stabilization, medication, housing, and wraparound behavioral health services. And it's our assertion that care plans should be based in the standard of care. So what is the standard of care? Next slide, please. I just pulled some recommendations from the American Psychiatric Association guidelines for the treatment of schizophrenia, and I tried to pull those recommendations that are most applicable to the population that I'm discussing here today. So one of APA's strongest recommendations is that patients who have schizophrenia be treated with an antipsychotic medication and monitored. So again, one leg in a three-legged stool. There's also a suggestion in the APA guidelines that patients receive treatment with a long-acting injectable antipsychotic medication if they have a history of poor or uncertain adherence. Again, this is the population that we're talking about, as I described, most of whom received no meaningful mental health treatment in the months preceding their arrest. And finally, the APA recommends the patients who have schizophrenia receive something called assertive community treatment if there is a history of poor engagement with services leading to frequent relapse or social disruption, such as homelessness, legal difficulties, including imprisonment. So you see, this is right on the nose. That's our target population. And the APA recommends that those individuals receive ACT, which is what we call this type of treatment. And I'll go into that in a moment. Next slide, please. Here's our three-legged stool, medication, wraparound behavioral health services, and housing. Next slide, please. So let's start with leg one of that three-legged stool, medication. Do medications work? Antipsychotic medications are extremely effective. In fact, you can achieve complete recovery or remission in a substantial percentage of individuals who've had psychotic symptoms. Adherence to antipsychotics is associated with symptomatic and psychosocial remission, as well as community integration. And it's important, even if you don't get complete recovery or remission, to note that the effect size of antipsychotic medications are similar to other medications for chronic conditions, which schizophrenia is, such as cholesterol medications or antihypertensives. So a good effect size, and especially effective at reducing positive symptoms of psychosis, hallucinations and delusions, which, as I hope I demonstrated, are the symptoms that tend to cause criminal justice involvement. Next slide, please. There's a great couple of studies showing that possession of psychotropic medication reduces the odds of arrest. The combined effect of medication and outpatient services reduces risk of arrest even further. 2 out of 3 legs of our stool. I mentioned the effect size is comparable to other medications for chronic conditions. And people with other chronic conditions also struggle with compliance. So if you're involved in care, if you somehow you find yourself involved with the care process, it's important to remember that good medication management involves building a therapeutic alliance, helping a patient understand, using things like motivational interviewing, really addressing side effects and working together like you would with any other patient. Next slide, please. If you take, as physicians, if you take nothing more away from this talk today, please pay attention to this part. This is the AMA Principles of Medical Ethics, and it's describing the process of informed consent. And the informed consent occurs when there's communication between the patient and physician that results in the patient's authorization or agreement to undergo a specific medical intervention. You all know this. It requires an assessment of the patient's ability to understand relevant information and the implications of treatment alternatives and to make an independent voluntary decision. In order to participate in informed consent, a patient has to understand that they have a disease. And as I hope I demonstrated to you at the top of this hour, insight is necessary for medical decision-making capacity. And 60% of people with schizophrenia spectrums don't have insight into their illness. Next slide, please. A court may order medication if it finds, upon review of the evaluation and hearing from the parties, the respondent lacks the capacity to give informed consent to the administration of medically necessary stabilization medications. So taken together, what does this all mean? Next slide, please. I think there is a misunderstanding about medication orders in care court, about the role of involuntary medication in care court. And as physicians, I just want to make this point very clear. What the court order in care provides us as mental health prescribers is the ability to overcome the barrier of trying to get voluntary informed consent from someone who lacks medical decision-making capacity. We treat thousands, we admit thousands of patients to our system every year in state hospitals who have medication orders. And it is extremely rare to do any sort of physical forcing of medication. What those involuntary medication orders allow us to do is operate in the gray zone represented in this graphic, which is the clinical opportunity to form therapeutic alliance, to use motivational interviewing. With care court, you have a black robe effect where the judge is encouraging the patient to take their medication. And all these opportunities to work with someone and get them stabilized on medication we do not have right now in psychiatry, because in order to give someone medication who's not giving you a voluntary informed consent, they have to meet a dangerousness standard. So it's a little thought about nuance to care court, but it's very important to understand that these court orders are going to be very effective at helping us get individuals stabilized on psychiatric medication. Next slide, please. This is just a worksheet that we put together for especially judges, but anyone looking at a care plan to make sure that that individual is getting robust psychopharmacological treatment. And there's a link to this on our website, but this is just to give you some idea that this is the art of medicine, and this is what we in psychiatry do, and these are all the things that we need to address with the medication piece of an individual's care plan. Next slide, please. Okay, so I talked about the first leg of the three-legged stool. This is the second leg, services, wraparound services. The gold standard is assertive community treatment as evidenced in the APA guidelines. It's backed by 50 years of research, and it's designed to improve housing stability, medication adherence, and overall functioning. And the key to the ACT team really is that the patient has an intensive, coordinated, integrated team that includes a psychiatrist that they know and trust. And that team is available to that person all the time. So I worked on an ACT team many years ago. We had a team pager. One of us took the pager home every night. So if that patient went into crisis at night or on the weekends, which is when psychiatric patients often tend to go into crisis, they could get in touch with us. We could meet that person and help them deal with whatever was going on. So this is what we're highly recommending for the services leg of the three-legged stool. Next slide, please. And finally, housing. Care will not work without housing. Housing has to be a part of the care plan. Maintaining stability and staying connected to one's treatment team is extremely difficult when that individual is unhoused. And here is just listed a wide range of housing options that can be tailored in an individual's care plan. Next slide, please. Right now, the counties that are bolded are the counties where care has been activated and is currently going on. So if you are a physician in one of these counties and you have someone who might benefit from care, I would encourage you to look into this option. And the remaining counties will be implementing care on December 1st of this year. There are some links in the slides that'll take you to the website where you can find petition forms and instructions on completing those forms. And the final bullet is important. We understand that our California physicians are extremely busy. And if you are a petitioner or a delegate, you do have to attend that initial hearing. However, the petitioner can be relieved and replaced in the CARE Act process by the County Behavioral Health Director as a substitute petitioner. Next slide, please. So I just put these bullets in. These were the people who are eligible petitioners. Doctors are eligible petitioners. And in the statutory language, these are some of the roles where I could foresee a physician being a petitioner. So the director of a hospital, the director of a public or charitable organization, a licensed behavioral health professional, the director of a county behavioral health agency, or the director of a California Indian or tribal behavioral health department. So this is where you as physicians can get involved in care. Next slide, please. That is the end of my talk. I do have a few minutes if there are questions. Thank you so much for spending time listening to me today.
Wow, thank you, Catherine. That was such incredibly rich information on an area, as I said in the beginning, that feels often kind of scary and controversial. And I love the way that you put that together in such a straightforward way. We have a ton of questions and probably not time for all of them, but one of the questions that seems to be coming up is, do we have the right services in California to make this successful? You talked about stabilization beds, wraparound, and housing. Does this do we need more psych beds? What kind of housing resources do we have? How hopeful are you when this gets implemented that we have everything in place?
Well, I have two thoughts around that issue. One is, we don't have everything we need now. We don't have comprehensive behavioral health systems in California right now. But we do have an administration that is pumping literally billions of dollars into different funding streams to try to build that continuum of care. You know, I would encourage you to go to the Health and Human Services website to see just the types of investments they are making. And I would argue, as a clinician who's kind of watching Rome burn, prioritize these people with the services that you do have, with the housing that you do have. These are the people who really need it the most. So move them up to the top of the list while we build out the infrastructure for some other folks.
Yeah. Yeah, that's helpful. And what about when you talk about the medications that are part of this CARE Act? Does this include medical prescriptions as well as medically associated treatment like buprenorphine and naloxone for addiction?
I think the language in the statute is fairly clear that it's stabilizing medications, and I think it's really directed at stabilizing someone's mental health symptoms.
Okay. So we'll have to manage those other medications on the outside. Okay. There were some questions about the CARE Act and minors. Is this relevant at all for the pediatric population, adolescents, et cetera?
No, you have to be 18 to qualify.
Okay. And then as this is beginning to be implemented, do you have any early stories? I didn't quite get the timeline. Has it just been implemented in those counties where it's already started? And is it just 9 days old, or when did it start getting implemented? And if it's been longer than that, are there early success stories or any sense of how it's going so far, challenges and barriers to implementation, et cetera?
It's October 1st was when the county partners started CARE, and we are hearing stories of inspiration. We are hearing about mobile mental health workers engaging people. We are hearing about petitions being filed. We're hearing from judges who are really invested and passionate, but I think it's probably too soon for the real big success stories that we're going to see later.
And then there's so much robust stuff in this presentation. I wish we'd had a little bit more time, but for a physician, say an ED physician who's seeing a patient who they feel like might need this program, can you just talk us through what would be the step in the moment that they need to get started on this?
I would go to the Judicial Council website, and there is a link in the talk that I gave, and there's forms and instructions on how to fill out that petition.
Okay, and just so that we understand, so you fill out a petition. They could do it in the ED while the patient is there, and how then? What's the next step? Just walk us through it.
Well, there's a series of different evaluations that have to occur with certain timelines that has to be presented to the judge to see if there's merit to the petition. And at that point, the behavioral health director for that county can take over the process. But there's a series of timelines where then a care plan has to be presented to the court, and so on and so forth. So but I think the most important part of this for our physicians on the call is filling out that initial petition, and then the process should take it from there.
Yeah, and just to be really clear, so you have this patient in front of you. How long is it going to take until they're, kind of fully engaged in this process? Where do they?
It's going to be variable depending on that person. There's a process where first you're trying to get that person to voluntarily participate before you go into the court-ordered participation. So I think what we're finding is, how it's laid out. We have, if you're interested, on our CARE Act website, the flow charts and the timelines. And what we're finding is, this is really sort of individual. We're not seeing any sort of trend where I could say something specific about how long it tends to take.
Okay. Well, super helpful. And I think that people are a lot more prepared today after this talk, both to really understand the complicated issues and why this is, it sounds to me like a very humane way to approach this very sticky problem. So we're all much more prepared than we were before. So thank you for that. I wish we had more time for questions, but I also want to thank Erica for presenting today's content. And thanks to everyone for listening in. Just a reminder, you'll receive that survey around 5 o'clock today, where you can attest your attendance. Once you complete that survey, we'll send out your CMA certificates within a week. And then our next session will be Tuesday, February 13th. We'll be again discussing California's mental health landscape, but from sort of the opposite point of view. We'll be giving folks brief interventions to empower frontline clinicians who are encountering anything along the whole spectrum of mental health acuity. So wishing you all a healthy 2024 and hope you all have a great rest of your day.
Thank you.